Hello and welcome to the short webinar looking on rehab principles following hip arthroscopy. Hip arthroscopy has evolved substantially over the last 10 years. It's revolutionized hip surgery due to less morbidity than open procedures. And the rehab has also progressed over the last 4-5 years with the increasing demands being placed on these patients on return to play. So in this short video, we'll be looking at some of the rehab principles. My name is Binoy Matthew. I'm a physiotherapist and an extensive scope practitioner with special interest in lower limb conditions. So if you look at the options for hip arthroscopy, there's plenty of options. Generally, open surgery is mainly used for osteostomies, and hip arthroscopy is used for corrective procedures such as osteoplasty and chyloplasty for CAM, rib trimming for pincer, labral debridement, microfractures and stem cells can also be used for chondrulations. It remains to be the gold standard for labral pathology diagnosis, ligamentum teres, as well as in chondrulations. Surgery is generally considered for symptomatic patients with suspected intra-articular disorders that do not respond to conservative treatment. Common indications are generally symptomatic labral tears and chondral injuries or loose bodies, FIAs and ligamentum teres disorders. The objective surgery is mainly to reduce pain and improve function, and to remove any mechanical or structural elements contributing to symptoms. Based on current literature, there is no evidence that prophylactic surgery is necessary or warranted for asymptomatic FIA. FIA is common even in the asymptomatic population, so the idea of surgery is mainly for pain reduction and improving function when they have failed conservative treatment. Historically, for the last before 10 or 15 years, it's mainly used for the athletic population. This study from Malavia and group had looked at nearly 122 patients, and what they found out was even non-athletes did well at a yearly follow-up with good results in both the groups. So it's getting more and more common, not only for the athletic but also for the active individual who is unable to progress because of his hip dysfunction. So the main question which I'm asked by many patients are whether the patients who are likely to not to do well. So this is an extensive systematic review which was published in the AJSM, and the key factors which were identified were older age, and the most important factor was presence of osteoarthritis before the surgery. So there was poor outcomes with the patient who had pre-existing osteoarthritis, and also people who had longer duration of symptoms were also likely to do well, and also people with poor functional scores. So how much arthritis is too much for hip arthroscopy? This systematic review had looked at nearly 15 articles with more than 2051 hips, average age of about 40.2. Out of that, nearly 345 got converted into total hip replacement after 3 years. So the factors which influence conversion were mainly pre-operative osteoarthritis. So even looking at an X-ray, if the joint space was less than 2 millimeters, these patients are more likely to require conversion to total hip replacement. So counseling is important for patients who already have established osteoarthritis, and also having clear expectations if they already have a joint with significant degeneration. Some of the common complications are the most common are tendinitis of the hip flexor, especially iliopsoas, TFL, and the rectus femoris. Some patients can also get numbness due to traction injury. Common nerves are sciatica, pudendal nerve, and femoral nerve as well. Usually, these symptoms usually resolve within few weeks. So it's important to reassure the patient. If there are any myotomal weakness or persistent neurological deficit, it's important to liaise with the surgeon. Another late complication which happens usually around a year mark is heterotrophic ossification. It's usually soft tissue calcification around the hip. Most commonly is around the rectus femoris. There is some evidence that taking anti-inflammatory during the first 2 to 4 weeks can prevent the incidence, and it's also important to avoid aggressive manual therapy for the first 6 weeks. It's important to remember that we can't give strict timelines to the patient, and generally a criteria-based progression is used at different stages. So in my presentation, I've used evidence from these 4 articles, which follow the principles of surgical management, post-op surgical management. It's also important to understand that impairments and deficits can exist even 1 to 2 years after hip arthroscopy. So this latest study have shown like even single leg squat performance can be impaired for a long time. So patients should be aware that the rehab can be long and will involve multiple stages. There is no agreed gold standard for the best protocol following hip arthroscopy, so it's important to link up with the surgeon's protocol, and this guide is not meant to replace the surgeon's guidance. So let's look into what happens in stage 1. So the stage 1 following the surgery is all about joint protection and slowly regaining a range of motion, especially in hip extension. It's quite common for patients to have 2 to 4 weeks of non-steroidal anti-inflammatory drugs, and also compression devices to prevent chance of clots. And there's a chance of hip flexor contractures. So one of the common practices is to lie prone for blocks of 15 to 20 minutes, about 4 or 5 times a day. So it might be a good idea to encourage the patients to do that, especially before they come for physio input. It's very rare for hip patients following scope to have total non-weight bearing. Normally it's between 2 to 4 weeks of partial weight bearing. It can be increased in patients, especially if they had labral repair. So conditions like microfractures or labral repair or reconstruction can be a bit slower. It's important to know that patients do feel surgical pain, especially scarring of the bones, especially if they had shaving over the cam. So adequate pain control is extremely important. Now, some of the common exercises used in these phases are basic range of motion, heel slides, pelvic tilt. It's important to get the deep hip stabilizers activated and recruited at this stage. So things like the prone heel squeeze, bridging, single leg hip abduction can be started at these stages. Isometrics are also a good place to start, and the tissue flexibility is important to be maintained, especially hip flexors and adductors. Bike can be started by the 2nd or 3rd week as long as the resistance is low, and normally I start them around an RPM of about 60. Once the stitches are healed and the surgeons have given the all clear, it's the best time to start the hydrotherapy. So even simple activities like pole walking and lower limb exercises are encouraged. It's best to avoid breaststroke because of the twisting of the hips. Once they've been weaned off from the crutches, they can be started on aqua jogging, which is a great cardiovascular exercises to improve the fitness. So on our 2-day course, we go through different stages in detail, especially 2, 3 and return to play, and looking at various criteria we use on return to play. So on day 1, we look at the differential diagnosis and manual therapy. And day 2, looking at the rehab, both post-op as well as conservative management, both for hip related groin pain as well as extra-articular pathologies. And we also explored common pitfalls and the reasons for failure of rehab in detail on our courses. Do you find differential diagnosis with some hip and groin presentations difficult? Want a clear understanding on how best to approach FAI, CAM or pincer hip impingements? This 2-day workshop, practical and evidence-based course, is designed for all therapists who work with physically active patients with hip and groin pain. The course will consider the evidence and how this can be integrated into practice. The active treatment section will look at manual techniques on day 1 and the rehab of articular and extra-articular pathologies on day 2. It is designed to be highly practical and full of clinical tips that you can put into practice immediately. For further information on the dates, the links are below the video. Thanks for listening, and I hope you found it useful.